Yeah.
This is Focus on Your Health. It's brought to you by Kingman Regional Medical Center in historic Kingman, Arizona. I'm T.G. Lafredo, and this week I am coming to you from the pharmacy department. My guest is Raquel Vertrees. She is a doctor of pharmacy, and she's an intern here. Hey, Raquel, welcome.
Hi, thanks for having me.
Thank you for having me. I'm excited to talk to you because this is we have a lot to talk about. We're talking about, in the big picture, we're talking about the field of pharmacogenomics. And when you said that to me, I said, I have no idea what that is.
It's a big word.
I'm not afraid of big words, but I didn't recognize that one.
Yeah.
So we're going to talk about that. That's very interesting to me. First, though, I do want to ask you a little bit about your pharmacy program. You're a resident here at KRMC. You're working with Dr. Linda Williams, who's a pharmacist here.
Yes.
And this is a pretty new program, right?
Yes, so I'm the second resident to come through the program.
Okay.
We are expanding, so it's next year we'll have 4 residents compared to just 1, so it's a pretty good program.
And it's a good time to get on board.
Yeah, good time to get on board. A lot of new exciting things coming aboard here. So a residency program is just extra training from your regular pharmacy degree, so you can have more of that clinical experience and be able to be more comfortable working in a hospital setting and really taking care of your patients.
Yeah. And let's see, so the first pharmacy resident, did you meet her on your way in?
She actually went to my school as well.
Okay.
So my school that I came from is in Vegas, which is the closest pharmacy school here. So we do get a lot of applicants from there.
Okay.
So I did know her at school. And then through the process, I was able to talk to her, and she told me how much she liked this program, which is one of the reasons why I applied here as well. And then I'm still in contact with her right now.
If I recall correctly, that's Dr. Larissa Chin.
Yes.
Correct? Yeah? Yep, she was delightful. We did a show with her, and she was great. And Dr. Williams decided that she really wanted to make this radio experience a part of your hazing, I think would be the right term.
It's very unique. Everyone who's applying to the program now, they keep asking me, what's this radio show you're doing? And that sounds so unique. And everyone keeps asking me, and I keep telling them I haven't done it yet, so I don't know what to tell you, but now I can tell them.
Tell them it's awful. Tell them the guy's really mean, and he puts the interrogation light up. And I think it's really interesting we were chatting a little bit before we started recording. I think it's really interesting to talk to people really at this stage in their career. You know, for me, it's an exciting time. It's an inspiring time. You don't get much time to rest, right? It's like run. And
it's a very busy year. It's a lot of stuff to do in 1 year, but a lot of really good experiences that I'll take with me for the rest of my life. Yeah. Just in this 1 year experience, I've learned probably more than I learned all in pharmacy school. You learn how to practice out in the real world, which is a lot different than just reading your textbooks and using that as a reference. It's a lot different being in the hospital setting and having to actually take care of real patients in real life.
And because the residency is not necessarily a requirement for a pharmacist, you leave here with something pretty nice on your resume, in addition to that experience, right? Yeah,
it does. It does give you that extra experience to make, I guess, my career more focused on clinical-based and be able to work in more hospital settings. It's kind of where pharmacy is going to nowadays. You pretty much need to be residency trained to be able to work in a hospital now. So it definitely does give me an advantage for getting a job after this year-long program.
That's very cool. Well, I was going to suggest when Dr. Chin, who was the first pharmacy resident, when she left, was there any sort of rite of passage? Did she give you the torch in any way? Or did she just say, well, good luck, you're on your own?
She gave me all the advice I needed. Yeah. Every time I had a question, she would be ready for even just a simple thing as when I moved here, how to find housing and stuff like that. So I ended up having to live with one of the residency coordinators for like a couple weeks because it's hard to find housing here in Kingman. Yeah. But Larissa was always there to kind of guide me through, at least easing me into the process. Mm-hmm. And of course, she left me a little gift when I got there, so I always felt welcomed.
I would suggest that you have, I mean, the advice is wonderful, and that's a good professional courtesy, but I think you should have like a KRMC pharmacy resident garden gnome, for example. Okay?
Yeah.
You get the garden gnome, and then the next person, the next group that comes in, they're the stewards of the garden gnome. And that doesn't have to be that, but something like that. You can begin this crazy tradition that years from now somebody will say, I don't know where this came from. It's
That's
weird.
true.
You know?
Larissa did hide her business cards in the office, so I'm planning on hiding one of mine in the office too, so they can try to find it.
Something fun like that. And then it helps to establish this chain that you've all passed through the same place, right?
I'll have to think of something.
Yeah, think of something. I think that would be a lot of fun.
It would.
Okay, so let's talk a little bit about pharmacogenomics. Recently you gave a Lunch and Learn presentation on this topic. The first and most important thing is let's define this term. What is pharmacogenomics?
Sure. So it's a really big word, but if we do break it down, we can see the first part of the word is pharm, which comes from pharmacy, pharmacist. So we can think of this like as medicine. And then genomics, we can think of that as genetics. So putting these words together, pharmacogenomics is the study of how genes affect an individual's response to medications. So even though humans were all so similar, 99.6% of our DNA is the same between all of us. However, that 0.4% actually is quite a bit different and leaves a lot of different rooms for variations between us. So we can have different genes that are work differently than one another. So the majority of the population will probably work one way, which is how we base our medication therapy off of. But what pharmacogenomics can tell us is if that minority of patients, that medication may be working too well in their body and causing side effects, or it can tell us if that medication is not working well enough, so the drug concentration is not growing in the body and you're not actually getting that effect of the medication. So pharmacogenomics is trying to tell us how you're going to respond to that medication, essentially.
So you said we're 99.6, but that 0.4% is, as a pharmacist, is what can really cause trouble for your work, right?
Yeah, so obviously not all patients are the same, and it is hard to predict who's going to respond differently to medications. So how your providers and your healthcare professionals generally prescribe medications is based off of what we call evidence-based medicine. And this is based off of clinical trials that are done on medications. So in this clinical trial, it was determined that the majority of patients responded well to this medication. Okay. So it was FDA approved because of this. However, it doesn't take into account those outliers or those patients that didn't do well with the medication. So you're always going to have that small population that's not going to do well with medications. So we're hoping one day to have a more personalized medicine to where every single person is going to get that right medication for them that first time around, rather than having to try 2 or 3 different medications before finding the one that works for them.
How did this field of study emerge?
So if anyone's heard of the Human Genome Project, that was when scientists were first able to sequence the whole human genome, and your genome is your whole set of DNA. So they were essentially able to sequence a human's whole DNA, basically laying it out on a piece of paper, and this occurred in 2001, which wasn't that long ago. However, now they were able to sequence this more frequently and more commonly because the price has significantly decreased. In 2001, that Human Genome Project cost them $200 million. Oh my God. Which is a bit unreasonable for anyone to pay for. Right. So now it only costs $1,000, which is about the price of smartphones now.
Yeah,
so
right. Yeah.
A lot more accessible for most people, of course, not everyone.
I mean, is this something that I can go to someone and say, I would like my genetic code or whatever? Oh, what would be the right term for it?
I guess to get your gene sequence, I feel like I don't think it's very common right now to do. Doctors are usually only doing it if they're having trouble finding the right therapy for a patient, like they've tried 2 or 3 things, then they're trying to sequence instead of sequencing first and then prescribing the medication. I don't know if you've seen the ads on TV for like ancestral DNA testing to see all that.
Is that legitimate?
It does. So it does take a swab of your DNA, and then it compares it to everyone else's swabs that they have to see who has similarities in what areas.
Who's related to Genghis Khan and stuff like that.
Yeah, I don't know if that's true, but that runs along the same lines as pharmacogenomics pretty much. Is looking at genes as well.
When I see that kind of stuff on TV, I always wonder if it's sort of like have a star named after someone you love, you know.
Yeah.
It's
pretty legit. There's some I guess drawbacks to it is that they're going to have your DNA on file because that's what they use to send everyone's results, is they base it off of the DNA they have.
In order to make this whole thing more palpable, do you have like a case study? Give us an example of a hypothetical patient and how this sort of study could work.
Sure. So let's just think of an elderly patient who comes into the clinic maybe complaining of feeling tired, not really wanting to eat regularly, and no longer enjoying visits from his family. He's already tried 2 other antidepressants, and these are more symptoms of depression, so he has not had symptom relief because of this. And then with antidepressants are the 3rd most commonly prescribed medication in the United States. And for each medication you try, you have to try it for at least 4 weeks. So if we're trying 2 or 3 different antidepressants to see if it's going to work, that's going to take about 2 or 3 months, and that's a long time for someone not to feel very well. So looking at this patient, if his provider then decides to run a pharmacogenomic test, he can see if there are different genetic changes in this patient's DNA to where his medications might not be working as well. So let's say in this case he finds out that this patient is we would call it an ultra-rapid metabolizer. So this patient is metabolizing medications really fast. So you can think of metabolism as like an enzyme or like a Pac-Man kind of eating up your medications really, really fast. And because of that, that medication can't build up in your body because it's getting eliminated so fast. So the patient's actually not getting any of the beneficial effects of that medication at all.
His system is too efficient, kind of?
Yeah. So what happens is he's still going to have those depressive symptoms because he's not actually getting the benefit of this medication. So if the physician runs the pharmacogenomic test and is able to see this, he can change the medication to another medication that isn't metabolized the same way as the ones he's previously tried. So this medication will be able to build up in concentration and work for the patient.
Could you talk a little bit about how we do metabolize medications?
Sure. So when we initially ingest a medication, our body's initial response is to get rid of that medication because it's foreign, doesn't belong there. So we can think of enzymes in our bodies like Pac-Mans eating up the medication and getting it ready to be eliminated from the body. So in normal metabolizers, they're not saying that anyone else is abnormal. It's just saying this is the majority of the population. They're able to metabolize that drug as we would expect, and that's how most of the patient population would metabolize the medication. However, sometimes you can have poor metabolizers, or you can have ultra-rapid or rapid metabolizers. So in poor metabolizers, you can think of that Pac-Man is working a lot slower, not working as well, so you're not metabolizing that drug as fast. And when you're not getting rid of that drug as fast, that drug starts to build up in your body. And when you have more concentration of drug in your body, that leads to side effects. On the other hand of this, we can have the ultra-rapid metabolizers or just rapid metabolizers. And you can think of this metabolism as extra fast. So you're breaking down that medication really fast. It's getting eliminated from your body really fast. And because of that, you're not actually getting the effect of the medication because that drug concentration is so low.
It's time for a quick break on Focus on Your Health. We'll be back in a moment for more with Dr. Raquel Vertrees. Stick around. Support for the Arizona Community Radio Network is provided by Kingman Regional Medical Center. At KRMC, we've doubled the size and capacity of our cancer center, investing in the latest technology to better serve our community. We're proud to offer state-of-the-art medicine and compassionate care right here at home. KRMC. And welcome back to Focus on Your Health. I'm T.G. Lafredo, and this week my guest is Dr. Raquel Vertrees. She is a doctor of pharmacy and a pharmacy resident here at KRMC. We're talking about pharmacogenomics, which is the study of how genes affect an individual's response to medications.
Okay, so let's return to, we have our hypothetical patient. I'm calling him Carl.
Okay.
All right, so we're back with Carl. We said that he's an elderly patient. He's suffering from depression. He's been on this medication. What's going on with Carl now?
Okay, so let's say now that his physician has decided to order the pharmacogenomic testing that looks at commonly prescribed mental health medications. Our mental health medications do go through 2 different enzymes that are pretty common to have genetic variations in. So let's say his results come back and he is a ultra-rapid metabolizer for one specific type of enzyme. These enzymes have really long names. They're called CYP2C19. We'll say this one is called, but they all have different names. They're all like a combination of numbers and letters. It's not really that important, but...
And is the code in there? Like, you know what it is based on the way it's named?
Yeah, so when we code or name these enzymes, it's based off of, there's a family of enzymes called cytochrome P450 in the liver, and then so there's little subfamilies of these, so they all start with CYP or CYP, which is short for cytochrome P450.
Why don't you just say that every time?
Because that's a mouthful.
Okay.
So they all have different combinations. They're either CYP and then a combination of letters and numbers. So we'll say this one is CYP2C19 ultra-rapid metabolizer.
How about you say that and I'll listen? Okay.
This CYP2C19 ultra-rapid metabolizer, we can think of this patient's metabolism as working really fast.
Okay.
So now the antidepressants this patient has been taking previously, they both worked through those enzymes. That's why the patient wasn't feeling any better, because they were both going through that enzyme. However, when the physician finds out that this patient is a CYP2C19 ultra-rapid metabolizer, he can pick a medication that goes through a different enzyme. And then because of this, our patient is able to feel relief after about a month of taking this new medication, because now that drug concentration is built up in his body and is starting to work.
Yeah. That's very interesting.
Yeah, it has a lot of implications.
It does. That's what I'm pausing to think about what this would mean. Is there something else we need to say about Carl? He's feeling better.
He's feeling better now.
Yeah. Let's talk about those implications. So I mean, where we are now in the evolution of this science, you have said that pharmacogenomic testing is not the first step. It's gotten more affordable, but it's certainly expensive still. Mm-hmm. So it tends to be, you know, when there's a problem, when the medication is not doing what you want it to do, then it's the follow-up, the additional tests, right?
Currently, that is how the process is right now. I hope for the future, someday we can all get our genomes tested, like first off, right when we go to the doctor's office, so they can be able to use that information right off the bat, rather than using it maybe like months after not really seeing an effect.
Right.
I've seen this more commonly used in psychiatric patients. If they've tried like probably more than 3, probably like 4 or 5 medications and still aren't feeling better, then I've seen pharmacogenomics used in practice to try to really pinpoint the area that they need to focus on and get that right medication at. But I don't really see it being used commonly in other areas right now. And this could be because it is a higher cost initially. Some of our poorer, more disadvantaged communities might not be able to afford that, so they wouldn't have the access to the higher level of care. And it can also lead to discrimination in some ways.
Ooh, tell me about that. How so?
So unfortunately, insurance companies play a big role in our healthcare.
Yeah, of course. Yeah.
Yeah, so they kind of rule the land, and it's unknown if they were able to get a hold of your genetic information, if they could discriminate you based on your rates, if they found out that you were at high risk for having a certain type of, I don't know, cancer or some kind of genotype. As in potentially saying we won't insure you. Yeah, or raising those rates. So that could be a big potential barrier, is your privacy. Right. So we're not sure how this would be kept private and if insurance companies will have access to it as well. There's also knowledge barriers right now. Of course, it is a newer field, so doctors and healthcare professionals that have been in practice for a while might not be up on this information and know exactly how to use it and when to use it. So it'd be a big step to be able to incorporate this into real life practice. It'd have to start being taught at schools and then kind of built up from there. And of course, there's a lot of information and there's a lot of medications that it affects, so there'd have to be some way to be able to teach everyone all this information to be able to use it.
I can't help but wonder if some of that will fall on you, like you and your classmates now moving on into this professional world.
Yeah, I definitely feel like this could be put onto pharmacy to look at.
You have to be the ones to educate the medical community, right?
And then pharmacy is more into how drugs are metabolized, and we look at drug interactions and everything that affects your medications right now. So I would think that in the future, pharmacists could play a big role in pharmacogenomics and helping physicians choose that right medication for the patient as well.
Yeah. We touched on some of the potential drawbacks in this field, and that, of course, that the testing is expensive, and there are safety concerns. Is there anything else that comes to mind that we should think about? I mean, because it sounds like it has so many advantages.
Yeah, I think the biggest drawback is going to be initially is getting over that initial price for insurance companies to be able to cover that initially, and then to realize that they'll get the benefit later on. So that's probably the biggest drawback currently. There's also currently a drawback of that there's lack of what we call clinical trials in this field, and that's because pharmacogenomics is going to focus on a smaller amount of the population, and because of that, it's only going to affect a smaller amount of people, so then there's not a lot of money in it for drug companies to do trials on.
Right, which is always the major factor, right? Yeah.
So because of that, we're not going to have a lot of evidence-based medicine on this kind of thing, which is how we usually base our medications off of. So that is also a potential drawback.
Yeah. When we began our conversation, you said something like, this is a more personalized, or could lead to a more personalized approach to medicine. So now I'll ask you, take a little look into your crystal ball. When you think about all that's changed in just 17 years or so of this field's existence, what do you think? Where do you see it going?
I mean, I feel like pretty soon we could see this become a lot more common. The FDA has recently approved this little handheld device that you can just use in a doctor's office that'll test for 2 common genetic changes you can have that are responsible for 25% of our medications interactions. And you can have these results in your doctor's office in an hour. And I see pharmacy and the future of personalized medicine kind of going towards this, and I feel like soon we're going to be seeing a lot more of these kind of tests becoming more common, and then being able to specialize and personalize our medications, hopefully.
Which could result in the long run, right, in more efficient medication and in a lot less wasted time and money, I would think.
Yeah, so this would be getting that best choice of your medication that first time around. And because of that, you're going to feel better. Patients aren't going to have to go to the doctors as much. They're not going to have side effects, so they're not going to have to go to the doctors as well. So both of these are going to lead to lower healthcare costs in the long run.
Can you imagine a world where pharmacy, where you've effectively eliminated the potential for side effects?
It'd be pretty amazing.
It would be amazing, wouldn't it?
Yeah. Because that's where most of our problems with medications come in.
Yeah.
Is patients can't tolerate the medication because it's causing some sort of side effect, but they need something. So it's always been a real hard to work around that. And then with this, we wouldn't really have to.
That's Dr. Raquel Vertrees. She is a doctor of pharmacy, and she's a pharmacy resident here at KRMC. Dr. Raquel, thank you so much.
Thank you. It was a pleasure being here.